All right, well, we'll get started. Thanks everybody for choosing to attend today's session and not listen to the federal budget. I'm sure you had to really think, okay, do I go to a stats talk or do I listen to the budget? So thank you for coming to this. My name is Rahul Mainra. I'm a transplant nephrologist in Saskatoon, Saskatchewan, and chair of the CST Education Committee. And I'm super excited about our Red Hot webinar series that has been ongoing since last fall. And Red Hot, for those of you that have not heard of it before, it's a research, education, development for healthcare professionals in organ transplantation. And we've got a whole 2-year curriculum of various research topics. And today's talk is by Dr. Joe Kim, where he's going to be discussing statistics, the exciting field of data and statistics. Dr. Kim is a staff nephrologist in the Division of Nephrology and director of the kidney transplant program at the Toronto General Hospital, University Health Network. He is also an associate professor in the Department of Medicine and the Institute of Health Policy Management and Evaluation at the University of Toronto. I come to you from Treaty 6 territory and the homeland of the Métis in Saskatchewan. I'm grateful for the land that my family lives in and where I work on. I see the disparities in health of Indigenous peoples in everyday life and work. And although I cannot change the past history of the mistreatment of our Indigenous brothers and sisters, I can definitely try every day to understand and walk in their shoes. And I hope I can carry this with me as a doctor, teacher, father, and I commit to those changes in my own work and life in the future. With that, I would like to hand it over to Dr. Kim, and we'll definitely have time at the end for questions, but if you have something burning that you need to write down, put it into the chat and we'll be monitoring the chat, and we'll definitely have some time for questions at the end of Dr. Kim's presentation. So thank you very much, Joe, for presenting today, and I'll hand it over to you.
Great. Thank you, Rahul. You can hear me okay? Perfect.
Yeah,
okay.
You bet.
Thanks. Thanks, everyone, for joining today. So we'll talk about my favorite topic, and Rahul's giving me the title, Talk the Talk, Knowing Your Stats. As you can imagine, the realm of biostatistics or statistics more generally is expansive and a lifelong sort of pursuit and discipline. So I'm not gonna be able to summarize effectively in 1 hour what it's all about. However, I'm hoping that I can provide you some insight in terms of some of the observations I've made that might be useful for you as well in this space. My background is, of course, I'm a physician, but I also have a doctorate in epidemiology and a master's in biostatistics. And I must say that master's is coming really handy for many reasons, both from the research that I'm doing, but also contributing to the research of others and so forth. So hopefully I can sort of help convey some concepts today that will be useful to you as well. I have no disclosure specifically related to this presentation. So I guess ultimately the question is, well, how did you want to come about to really understand and use statistics? Well, ultimately you're going to need to do some work to, go through sort of the relevant sort of principles and concepts that you need to learn through maybe formal coursework. You have to apply it. You have to work with other smart statisticians and so forth to sort of learn about the application of these methods, publish your findings, and then of course get the accolades that you deserve as it relates to that. And this is a many-year endeavor to sort of come to that understanding. So it's, as I said, it's not something that we can easily summarize in a span of less than an hour. But what I will try to do is take some of the experiences that I've had as a statistical editor for Kidney International, which I've been a statistical editor for almost a decade now, and as well as for the American Journal of Transplantation in the last couple of years, and provide some insights in terms of what I've seen are frequent misunderstandings or even frank misuse of statistical concepts. And so hopefully it can help you to avoid them and potentially use statistics more effectively in your own work. I'm just going to ask everyone to mute your mics, just to hearing a little bit of background noise. Thank you for that. Okay, so these are the 5 topic areas that I'm going to tackle today. And they're, of course, not the whole spectrum of statistics, but these are areas that I see come up over and over again in manuscripts that come through both Kidney International and American Journal of Transplantation. So I hope we can sort of delve into these, and also some of the concepts that underlie them will hopefully be more broadly applicable in terms of other areas of statistical sort of methodology and so forth that you might encounter. So first is interpreting p-values, or maybe the misinterpretation of p-values, the issue of what a retrospective versus a prospective cohort study is all about, the three domains of what we do in research: description, prediction, and causal inference, and what they are, how they're different, and how to sort of use them. And then the other issue around regression models, in particular, how you select variables when it comes to regression models, a persistent problem that I see in the published literature. And finally, if we have time, hopefully, we can talk a little bit about analyzing follow-up data statistically and some of the vagaries that I see in the literature as well. So let's first talk about p-values, because it's such a fundamental principle around sort of the statistics that we're used to. And there's a lot of misconceptions around what the p-value is, but it's of course published everywhere. So I'm going to provide you 4 definitions of p-values, and I'm going to actually get some of your thoughts here. So the first definition of the p-value, or at least the perceived definition of the p-value, is the p-value is the probability that the null hypothesis of no difference is true. The second variant is the probability that of the observed study result occurred by chance. The third is the probability of observing the result that you saw or something more extreme under the null. And finally, the probability of making a type 1 error. So, we didn't prepare a survey in advance, but whenever I've asked this question in other fora, I usually get kind of a smattering distribution across these four sort of results, or 4 sort of items, as the response to the question of what a p-value is. So a lot of misconceptions around p-values. I'll tell you right off the bat that the answer is the third one. And the reason why it's not the first one is because the p-value actually assumes the null hypothesis is true. So there's no probability statement about the null hypothesis. The second issue highlights the fact that it's a probability statement about a specific result, and it's not. It's about a result of what you saw or something more extreme, which is reflected in the third correct statement. And finally, the issue of type 1 error, which very frequently is conflated with the p-value. A type 1 error is set in advance of the study as a threshold for decision-making, typically 0.05, whereas a p-value is actually calculated from the data itself. So again, 2 distinct concepts, one set in advance and decided upon a priori, the second one being actually calculated from the data. So what I thought I'd do is I'd go through with you what a p-value is and the mechanics of it. Okay, and so just to give you an understanding of how the p-value is generated, and as a result, hopefully better ways to actually interpret it and use it in your own research and interpreting others' research. So this is the famous Bell distribution, the Gaussian normal distribution that you would see in a lot of textbooks and so forth. And you can see here it's centered around 0. And so you might ask, well, what does this Gaussian or normal distribution represent? Let's say I'm doing a clinical trial of a blood pressure agent, a novel blood pressure agent versus a comparator, and let's just say the standard of care at this point. And I'm interested in the potential effect of that new agent on reducing systolic blood pressure. And so that's the sort of the goal of the trial, is to get a sense of how much this new agent reduces the systolic blood pressure relative to the comparator, which is the standard of care. So typically what we do in the setting of calculating a p-value is you first have to set up a test, set up a scenario where you can come up with that value. And so what you're doing here then is, in the setting of a hypothesis test, as many of you may be aware, for those of you who've taken some introductory statistics, you're trying to sort of set up a straw dog or a straw sort of man to sort of say, look, I'm going to assume that in this comparison that there's no difference right off the bat, that ultimately there's going to be no difference between treatment A versus treatment B, and therefore the difference in systolic blood pressures on average will be about 0. So this distribution represents that difference, represents that statistic, so to speak, which technically is the correct term here, that sort of a measure that of interest in this particular trial that you're trying to get at the end of it. So it could be a difference measure, it could be a ratio measure, but let's say it's just a difference measure here because it's simplest to interpret. And I'm going to assume that there's no difference. That's how we just set up this hypothesis. And so in the middle of this distribution is 0, the non-difference distribution. Now the question is, what does the rest of this distribution represent? Well, in a randomized controlled trial particularly, what you're going to do is you're going to flip a coin, and let's say it's a 1-to-1 design. So you flip a 50% probability, a coin that gives you 50% probability of getting treatment A versus treatment B. And in any one rendition of the trial, you're going to flip it. Let's say you've got 2,000 people and 1,000 in each group approximately. After you flip it 2,000 times in each group. And after doing so, let's say you allocate one group to the new treatment, the other group to the comparator, and you follow them for some defined period of time, and you measure their blood pressure differences across that time, however you want to do it, and then you compare them at the end of that time. And so you've done one trial of that population, 2,000 patients, or that study sample of 2,000 patients, which then at the end of it all renders some result, a difference result. And that might be zero, but just by chance, it might be something else. It might be sort of over here. It might be sort of negative something here, or maybe positive something here, just by chance. Even if we assume that that treatment actually has no effect. Okay, so let's just assume, as we did in the null hypothesis, the treatment has no effect. And so in that context, any one rendition of the trial could give you a result that either is zero or maybe a little off of zero. The other thing to keep in mind, though, is then if I had access to a time machine where I can put these 2,000 individuals into that time machine and bring them back to the time that I originally allocated them to the treatments that then led to that result that I just saw. But now, instead, at the time of that original allocation, now I'm gonna flip the coin again, and it's gonna come up with a slightly different allocation across the two groups, right? So Mr. Jones was previously in the treatment A, may now just turned out to be in treatment B, for example. And that's just the luck of the draw. And so you do that randomization again, and then you follow the patients forward in time, the same period of time, by the way, because you brought them back in a time machine. And then you take that difference of their systolic blood pressure measurement, and then you document that result. And theoretically, you could do that over and over and over again for every conceivable combination of 2,000 people allocated across two groups with a 50% probability, right? There's some very large number, but there is some finite number of groupings or combinations that you can come up with in that scenario. And so this distribution represents all the differences in systolic blood pressure across all those possible trials, with the assumption that the treatment has no effect on the systolic blood pressure. So therefore, this distribution is also known as the sampling distribution, by the way, in statistics. That difference measure, this distribution sits right at the difference of zero, because that's what we know is the effect. There's no effect as we've assumed it. But then you're going to always have a bit of a smattering of those other effects that you could have had, even with the assumption of no effect under this distribution. So this is what we call the null distribution, right? All the conceivable values of every conceivable trial that you can do under these conditions, where you're looking at the difference in systolic blood pressure, centered on zero because the null is assumed that there's no difference. Now, what you're doing under this distribution is in the one time you did the trial, okay, you're going to come up with an estimate of the treatment effect, and it turns out to be, let's say, X out here, whatever that is. And in that one rendition of the trial, now you're going to take that value, and then you're going to look at it under the null distribution, and you're going to calculate the area, the tail probability of that value or something more extreme. Okay, you can see it in the dark area here. And typically, before we start a trial, most times we don't know for sure whether the treatment's going to be provide you quote unquote harm or benefit, or increase your systolic blood pressure or decrease it. We don't know. So that's why we tend to do two-sided p-values, and so we would double the quantity that you get from this area to give you the two-tailed p-value probability. So you can see here what I've done is, under the null distribution where I assume no difference, I can see where my rendition of the trial resides, okay? Or the trial that I did actually do. And what the current paradigm is that if that number represents, that p-value represents a small number, less than 0.05, then I'm going to make a leap. I'm going to make a decision that even though I could see this value, see the value that I actually saw under the null distribution with a probability that's less than 0.05, but still a finite probability, I'm going to make a leap and say, you know what? In all likelihood, this difference was not under the null, but actually the effect, there's a real effect. There's a real effect of this blood pressure pill. And the best estimate that I can make of it is that value X, okay? But you can see there, I use the term leap very, very deliberately. There is no logical connection between my statement around what I saw, or something more extreme in the probability statement, and the fact that I looked at it under the null, and then going on to say that actually, I'm going to decide that actually the value I saw comes from a different distribution altogether, okay? So that's what the p-value does for us. It's a decision tool, but we have to be the way we use it is that we make a decision that goes beyond the actual data itself. Okay? And this is where the controversy lies around p-values. It's not that the p-value itself is inherently problematic, not at all. There's a very strong statistical foundation for it. It's just how we use it. So therefore, it's important that we understand where it comes from. So now we understand it as a group that the p-value is a probability statement of what we saw in our trial or something more extreme or study, that what we saw or something more extreme under the assumption of no effect. And if it's quite extreme in the tail, then we're going to make a leap and make a decision that the effect I saw there, it comes from a different distribution, most likely a distribution centered around the value that I did see, but not under the null. Okay, so that's a key difference. So in the caveats that I want to highlight then is really the problem with p-values is they can be quite enticing. They seem to provide a summary of the evidence underlying what you saw, but really it isn't based on what I just described to you. And so you have to be very careful. The objective of clinical research is not the p-value. It's to quantify the effect, that difference effect, with some measure of uncertainty around that. That's the objective. So you should never, ever see a table in a paper with just p-values. That's sacrilege. That should never happen. Unfortunately, it doesn't happen anymore as far as I can tell, but this used to happen much more frequently in the past. And as I mentioned, the p-value can be a rough guide to the statistical evidence for what you saw versus the null. But again, because if that probability statement is very, very small, then yes, then that value that you saw under the trial that you did was or that study that you did was quite extreme relative to the null distribution. But it's not to say it couldn't have happened, right? So there's still a non-zero probability, but it is extreme. And so therefore you're going to make a decision on the basis of that. And that's okay, but you just have to be honest about what you're doing. And then remember that 0.05 threshold is arbitrary. R.A. Fisher, a very famous UK-based statistician who came up with the Fisher's exact test, the ANOVA, and a lot of other statistical innovations, literally said, you know what, 5% error rate in that regard seems to feel right? And that's how it came about. So just want to highlight that the p-value has a very specific definition. There is a statistical basis for it. It's sound, but how we use it can sometimes, how we use it in everyday practice can sometimes, and a lot of times, go beyond what was intended to be used. Okay, so but nevertheless, it is helpful. But I would say probably more helpful is beyond that is to make sure that we focus on the estimate of interest as well as some range of plausible values, typically in the context of a confidence interval, to give you a sense of the range of plausible values that you'd be looking at that are compatible with the data. Okay, and so that gives you much more robust information. And don't just use the confidence interval to essentially as a surrogate p-value, looking at the lower end if it crosses 1 or 0. That's not helpful. You need to look at the overall range. And even if you see a quote unquote statistically non-significant result, make a comment on, remember, because the point estimate you saw is the most likely value, and the range of possible values are actually diminished more so near the tails. And so therefore you have to think, is the estimate I saw something important, even though precision might not be there? And is this something that's important enough that we would want to carry on to another study to sort of refine that further, maybe look at another population and so forth? And there are other approaches like likelihood Bayesian approaches that sort of have a better way to sort of estimate the probability of your hypothesis being correct. But of course, they have their own assumptions as well. So bottom line here is that the p-value should not be negated or abolished, but it needs to be used thoughtfully in conjunction with the measure of association or effect estimates, along with measures of uncertainty. And these are some papers that I would sort of recommend as sort of providing you some further insights on that. So the older paper in 1999 is a two-part series at the Annals of Internal Medicine, and the more recent one, the European Journal of Epidemiology, is an excellent read, and many investigators use that paper as a basis to respond to reviewers for their manuscripts. So have a look at that and hopefully you'll find that useful. Okay, moving on to the second concept of retrospective versus prospective. This is a very common issue that comes up in a lot of the manuscripts that I see is the idea that somehow retrospective studies are inherently inferior to prospective studies. The problem is that it's the understanding around what this means is very, very highly variable, I find, in the published literature. So what does retrospective mean? Well, in this context, it simply means that you're using an existing data source or sources, be it a clinical database, an EHR, or administrating data sets. And so that the study question or hypothesis that's generated is done so after the data have already been collected for potentially other purposes. So they already exist, but you sort of come up with a hypothesis or a question that you want to test in the data after the fact. Now, there are certain types of studies, and I think Dr. Marquez mentioned this in his previous talk around case control studies, that that highlight. By the way, I'm happy to share these slides, so you don't have to take any notes. I will send these to Dr. Mainrad, and you can distribute them widely. The case control study is a type of design that, by definition, is retrospective in the sense that the sampling is based on outcome. So the measurements have already occurred, the outcomes have occurred, therefore you're coming up with the estimates there afterwards. Cohort studies, however, which is, of course, I would say the sine qua non, or the fundamental study design that basically all other studies designs come out of, is the idea that you have a group of individuals who are susceptible for the outcome, not having had it yet, but then you categorize them or group them into various exposure groups, however you want to do it, and follow them forward in time to the outcome of interest, and you compare them across the exposure groups. So that's a classic cohort study. In that setting, cohort studies can be prospective, also known as concurrent, or retrospective non-concurrent. But I want to sort of emphasize the following point. A lot of times I'll see in literature, even with these cohort studies, that if it's a quote unquote retrospective cohort study, the retrospective part is an inherent limitation of the study. That is wrong. 100% wrong, okay? And so the question is why, all right? So let me just show you the structure of a prospective cohort study versus a retrospective cohort study. And I think you'll sort of see why I'm saying this. So look, at the prospective cohort study has this structure here. We have a population of potential individuals who could be entered into your sample, into your actual study population or cohort or sample. And this yellow rectangle represents the actual sample that you've sort of acquired in your study. And this is a prospective cohort study. So the time point at that this is happening is the present. So you're recruiting patients, you're making measurements, you're storing specimens, whatever you need to do. And then you're following them forward into the future. You can see here it says the future, forward in time into the future, and delineating the outcomes that are occurring, along with addressing all the losses and follow-up and so forth. Okay, so you're looking into the future, but you're ultimately then measuring the outcomes of interest, and then you're gonna, at the end of the cohort study, then you're gonna sort of compare the outcomes across the different sort of exposure groups and so forth to come up with some estimate of the treatment effect, for example. So that's a prospective cohort study. A retrospective cohort study looks exactly the same, except the assembly of the cohort occurred in the past, but you're still following that sample or that group forward into the future. It's just that it occurred in the past. That's okay. It's still going forward into the future, where you're enumerating the outcomes, you're accounting for the losses to follow up, but it's moving towards the present, right? Because the data have already been captured. But the structure of the study itself is exactly the same. Okay, exactly the same. So the question is, what is the actual difference apart from when the data was captured? Well, the main difference is that because the data in a quote unquote retrospective cohort study is already available to you, and specifically not just the data at entry, but all the outcome data and things that happen after entry, there is a seductive tendency to want to use those data that were captured post-entry as a basis for defining inclusion-exclusion of patients. That is a no-no, okay? And it's actually fairly simple to think about in the context of designing studies. If you think about reconstructing a prospective cohort study using pre-existing data. So situate yourself at the time in the past when the patients did enter into your data set, whatever that may be. So for example, when they got a kidney transplant in the past, situate yourself there and decide, other stuff in the data set that already has been collected, would I have had access to that at the point that the patient entered? I.e., would I have known that they had an acute rejection 6 months later? No. So therefore, the acute rejection that is currently in the data set, because it was captured in the past, cannot be used as a basis for decision-making around who's entered and who exits the study. That is an outcome that has occurred over the follow-up period that needs to just be accounted for, okay, appropriately, be it an outcome of interest, competing event, censoring event, whatever. But the point is, at the entry point, that information was not available. So the key issue is making sure that you do not use any follow-up data in the data sets that you already have for the decisions around inclusion-exclusion. And as long as you do that, then at least at entry, the validity of the way patients enter, if you apply the same criteria as you would in a prospective cohort study, is the same for the retrospective cohort study as well. The other issue or potential difference between a prospective and retrospective cohort studies is the existing data source. The point is you have to make sure that the data quality itself, in terms of its completeness and breadth and what is captured, is appropriate for the study question. And so sometimes, because Out of convenience, you might use an existing data source, but it might not be perfect for the question at hand. You might not have all the variables that you want and so forth. So yes, that may be an issue. And it's a little more likely in a retrospective cohort study where data already exists versus data that you can collect in the future for a specific study purpose. However, if that's the case, don't just use the term retrospective as the basis for your conclusion that the studies has a weakness. It should be based on those specific issues. Okay? But having said that, if the data source, which already exists, is perfect for addressing your study question, there is no inherent difference in terms of the quality of that study in the retrospective sense versus a prospective cohort study. Okay, so I think from this day forward, using the statement that one of the weaknesses of my study is that it's retrospective should be abolished from your vernacular. Okay, and if you are going to say something to that effect, think about the next step. Why? Why are you saying that this retrospective, typically cohort study, would somehow be inferior to the prospective cohort study? And be specific about those reasons. Okay, and I bring this up all the time in my statistical reviews with the authors to push them a little bit about these specific issues. I'm providing you another sort of paper reference, a little bit of shameless self-promotion here, a paper that I published with one of our fellows, Sonia Rodriguez-Ramirez, that specifically speaks to transplant nephrologists, but it could be to any transplant doc or docs in general, around sort of an approach to addressing research questions in the clinical research context. Goes over the same issues I've sort of highlighted as well, and you may find this useful just as a general read as well. All right, so moving on then to the issue of description, prediction, or causal inference, a really important piece that I think is not frequently sort of highlighted. So what are the tasks of the clinical researchers? Like as clinical researchers or researchers, and again, I'm focusing more here on clinical sort of epidemiologic research, so not as much bench research, but what is it that we do with data? And if you break it down, there's only three things we really do with it. We either do analyses that describe something, so a descriptive analysis, description. We also do analyses where we would try to predict something, typically either currently right now or in the future. The prediction of the current is usually a diagnostic prediction. But the prediction in the future is, of course, a prognostic prediction, okay? But it's still prediction nevertheless. And then finally, the third group is inference or causal inference, also known as counterfactual prediction, where we're trying to understand how things work, right? One scenario versus another, and so a classic RCT, for example. So let me just go into this a little bit more detail. So description, which is the first task, it tends to use data to try to quantitatively summarize features of the world. So it describes, it tries to show what's happening in the world. And the analytic techniques that are involved in this can vary quite a bit. It can be very, very elementary, like medians and means and other measures of central tendency and measures of dispersion, all the way to much more sophisticated methods like unsupervised learning in the machine learning context. And so, or it can be simply some very clever data visualizations, as you can see here. The top panel here shows a very typical dashboard that you might see in any hospital for analyzing patient experience, whereas you can also have very sophisticated dashboards like the Hopkins COVID-19 page that did a wonderful job tracking the incidence of COVID-19 across the world, for example. So it can vary in sophistication, but ultimately it's just looking at data and quantitatively summarizing data in relatively simple ways, bar charts, sort of distributions across geographic regions, actual numbers of cases, rates, and so forth. And this can be extremely useful in the right context, particularly in terms of decision-making around resource allocation and where the hotspots of disease may be so that you can decide what kind of public health interventions are necessary. So descriptive analyses actually have been given short shrift, especially in clinical research, because we tend to focus on modeling all sorts of things. But where appropriate, descriptive epidemiology or descriptive analyses can be extremely powerful and very, very helpful. So that's the first thing we do as clinical researchers or researchers in general, is we use data for description. The next task is around prediction, okay? And so what we're doing there is we're using data to map certain features of the world, what's also known as inputs in the machine learning world. And then we're mapping that onto some other features of the world called outputs or outcomes or responses, whatever we want to call it, okay? And then the techniques here can vary quite a bit too. It can be as elementary as simple correlation coefficient, all the way to more sophisticated machine learning techniques like supervised learning, okay? Or the more traditional regression model, which you see here. Okay, this is a regression equation, a typical linear regression model where y is some mean effect of something, like for example, systolic blood pressure. Beta 0 is the intercept, y-intercept, and each of these x's represents some variable of interest. It could be a treatment, right? For example, this indicator could represent the new treatment that we talked about, treatment A, and then the referent would be the placebo or the comparator. X2 could be age or some other feature or characteristic of the patient, and so forth. Okay. The epsilon term, of course, is always required in the linear regression. It's just an error term, but you can ignore that for now. And so the question around prediction is, what's the goal here? Well, the goal is actually to get the Y right. Okay. So the idea here is and we'll talk about this in the context of variable selection afterwards, but you want to select a group of variables on the right side of this equation, right side of the equal sign, that does the best job possible in predicting the Y accurately. Okay. In this case, let's say systolic blood pressure, but whatever. Okay. And so the idea here is that you build a model with the sole purpose of doing the best job possible to predict that Y. Having said that, you also want to do it as parsimoniously as possible, meaning that you want a model that's simple but no simpler. Okay. And also, you want to build a model such that it's as generalizable as possible beyond your own data set. Because theoretically, of course, if you add enough variables into your model, you can almost perfectly predict. If you put a variable in for patient in your model, then you can perfectly predict what happens to every patient in your data set. However, try to generalize that to another context, you can't. And so it's a balance between prediction, the goodness of the actual prediction itself versus the generalizability of that model, which then can be overall captured in what we call prediction performance, okay? And so anyways, the goal of prediction, which is very useful and is now used more and more because of machine learning, and which is a sophisticated way of doing prediction, is to get that Y right, okay? Now I'm going to distinguish that with causal inference, which is the third task. Excuse me, and causal inference is not as much about mapping features or characteristics of the world to some outcome of interest, such that we can predict that outcome in not only this population, but in other populations and maybe in the future, okay? Like, for example, a sepsis tool where you can predict who's going to develop sepsis in the hospital. But in this case, causal inference is all about trying to sort of understand some feature of the world, be it a treatment or whatever, compared to its absence or something else, and what would happen thereafter. So it's the question of what if. What if I had this treatment versus a comparator? What if I had that? What would I sort of see in terms of some outcome of interest? And so you can imagine, this is actually the domain of a lot of the things that we're interested in clinical medicine, right? Is the issue of how do treatments work, for example, or what's the effect of this exposure on the outcome. So causal inference is really around that piece, which is fundamental to what we're trying to do. And so, example, as I said, the effect of a new treatment or placebo on the future risk of some clinically relevant outcome is an exercise in causal inference. Okay. Now, before I go on to what that means in the regression model, I think one thing that some of you might be asking is, well, what about association? We shouldn't be talking about causation, especially if we're talking about observational studies, for example. I would say that's incorrect. So I think we've, for a long time, shied away from making statements that we ultimately are trying to make, which is we're trying to come up with a statement that's causal, right? Ultimately, at the end of the day, that's what's most important and interesting. Yes, ultimately, what you see in the data set is associational in the sense that you see this linkage, you see this hazard ratio that's greater than 1 or less than 1 or whatever, but really want to make a causal inference about that. And so we're hesitant to do so in the setting of observational studies, whereas in RCTs, we feel more confident. But let me tell you, first and foremost, all studies need clinical research studies as it relates to treatment effects or exposure effects. All studies of that nature produce associations, period, full stop. Now the question is that association that you see, is it close to the causal relationship that you really want to estimate? Okay. And that closeness varies depending on the rigor of the design and analytic approaches you've taken. The RCT has the benefit of randomization of one of the most powerful tools to reduce bias, specifically confounding bias, and also other features of the study like rigorous measurement, entry into the study and follow-up and so forth, which reduces measurement bias, which reduces selection bias and so forth. So therefore, we have greater confidence that actually the estimate or the association we see is as close to the causal effect that we're trying to estimate. But at the end of the day, we don't know. Remember I showed you that bell curve, right? That was an RCT. We don't know if it actually lands on 0. The trial that you did could have been off just because of sheer chance. So ultimately, you're seeing associations. That's what we're always seeing. But the question then you have to ask yourself next step is, how likely is that relationship I'm seeing or association I'm seeing as close to the causal relation that I want. And so even with observational studies, if you do a good job of it, you can make a more confident statement that maybe this effect is likely more causal than not, okay? But you'll never know, because by the way, at the end of the day, the results you see in your study, the output of your study, the tables and figures you create, they tell you nothing ever about the validity of your study, okay? The data that you get out from your research tells you nothing about the validity of that result. It is what it is. The only way to make some statement of the validity is if you had done the work to make sure that the rigor with which you applied the design concepts and the analytic concepts follow the core principles of epidemiology and biostatistics in ways that give you greater confidence that the results are more likely valid than not. Okay, so the data itself rarely can give you actually reassurance of that. Now, having said that, going back to this slide, I showed you earlier the regression equation, and I said that in the context of prediction, our whole job is to try to get the Y right. So you have to assemble a group of features or covariates or what do you want to call them to really sort of come up with that Y prediction well, while at the same time not adding too many of them and making sure that it's generalizable enough so that it can work in other populations. In the causal inference space, my job is to get the beta 1 right. Okay? And when I'm saying beta 1 here, I'm saying because let's say X1 is some treatment or some like I said, treatment A versus treatment B, and that's what that covariate represents, and that's what I'm really trying to estimate. Well, then I want to try to estimate the beta 1, the treatment effect, as accurately as possible, okay? And so the inclusion of other covariates or variables in the model, the purpose of that, which I talk about afterwards as well, is not as much trying to predict the Y, because the Y is already there, and it's being used as a basis for me to come up with the best estimate or the most accurate estimate of the treatment effect. Those other variables, they're to account for the potential for confounding, right? The fact that those other factors could be the one driving these relationships. So if you want to try to hold those constant, then we can come up with hopefully the most unbiased estimate of the treatment effect, which in this case is beta 1, okay? So I find that that's the most useful way to think conceptually about the difference between prediction and inference/causal inference when we talk about data, is that frequently we model the data in a regression model. Trying to get that Y right is the whole job of prediction, whereas trying to get the beta for the specific exposure or treatment of interest as unbiased in a way as possible is the goal of causal inference. Okay. And this is just a few examples under those description, prediction, causal inference banners that just to give you a sort of an explicit example of this in the clinical research context. I'm just going to sort of leave this for you to have a look at, just for the sake of time. And this is the paper that a lot of these insights were drawn from. So if you're interested, you should have a look. This is Miguel Hernandez is a leader in this field in the area of causal inference from observational data. He's a physician himself as well, but also has a doctorate in epidemiology and a master's in biostats like myself, but he's much smarter than me. And he's out of Harvard and has done a lot of work in this space. Okay, moving on to variable selection then. For regression models specifically, there's two major topics I want to discuss here because it's, again, a frequent problem that I see in the context of the manuscripts I've reviewed. Selecting the types of variables for entry into a regression model is one challenge, and the other one is the number of variables that you're going to enter into a regression model. So let's tackle both of those. So the first one is the issue of types. So the types of variables one should include in a regression model, it depends on the objective. And now I'm going to sort of call into this slide what we just learned about two of the major objectives of research, which is prediction and causal inference or inference. I've just said it short form inference. So in the context of prediction, the whole goal of selecting those variables on the right side of the equal sign is around improving the prediction performance of that model, i.e. getting the Y right? So the selection of those variables is entirely guided by the accuracy with which you can predict that Y in the data set. While at the same time understanding that you want to be able to generalize those results to other populations. So you don't want to make the model overly complex. You want to make it as parsimonious as possible. And there's different metrics to tell you how well the model fits and so forth, right? So that's the goal there. So the types of variables you enter in the model on the right side of the equation is contingent on whether you want to predict versus if you want to do the inference part, which is the second one, where you really want to estimate the specific beta of a treatment or exposure. There, the selection of other variables is very important because then it controls for confounding. controls for confounding where that beta that you're really interested in could be biased as a result of the coexistence of other factors that may actually be driving the relation that you're interested in. So you need to control for those things, and those are the things then you're incorporating into your model. Now you might ask yourself, how do we go about doing that process? So let's first talk about prediction. I'll go on to the second piece. So like I said, choose a set of variables in prediction that provide the best model fit that lead to as accurate predictions as possible. Okay. Now, having said that, you don't want to just throw the kitchen sink at the model. You should have some sense of what you think are the major drivers of the relationship. So you want to select variables that you think are related to the outcome in a reasonable fashion that provide you information, preferably independent, or what we call in statistics, orthogonal information about what the likelihood of the outcome is. Okay, and they all then cumulatively contribute to predicting that outcome. Okay, so you want to base that on clinical knowledge, prior studies, and so forth. But still, the goal, as I mentioned it in prediction, is to really try to get that Y as accurately estimated as possible. Okay? The other thing to do in terms of model fit is that you may have to consider not only entering the covariates or the variables, you may also have to interact them, meaning that you create like multiplicative functions and so forth. And for those of you who have done some regression modeling, you'll know what I mean. So it's all about sort of trying to fit that model in ways that predict that outcome really effectively. One thing I'll make a point of here as the last bullet is stepwise variable selection procedures are pretty popular, but they are highly problematic for many reasons. Number one is that they lead to fairly unstable models in the sense that the covariates that you tend to select are probably either too few, or the estimates that you're getting are, because they're driven by p-values, are overinflated. And as a result, not only are the betas incorrect, but the actual predictions tend to be quite flawed as well. So in general, stepwise procedures is not ideal, at least alone. And they should typically, variable selection should, even in the prediction context, should be guided by some rationale, be it biological, clinical, plus or minus other variables that you think would meaningfully predict the outcome. But again, with the goal that you're trying to get that Y right, okay, the Y, the output. Causal inference, on the other hand, is around, as I said, choosing those variables in ways that reduce bias in the estimation of the beta of interest, okay? And here, subject matter knowledge really matter. There's no data-driven way to select those other variables, okay? And so this is where machine learning cannot do this, right? So this is one area where maybe machine learning eventually will be able to sort of have the sentence of a human being where they understand nuance and sort of understand context in ways that we can. Who knows? But at this point, there's no way a machine can decide, the causal structure of something unless you codify it. And even there's different causal structures you can test. They can all generate the same result, but they all may come from different causal structures. And so you, as the expert in the field, will have to make a decision about what causal structure is the most appropriate, because that'll determine which variables you enter in the model, and you'll have to be able to defend it. And there are tools now, specifically directed acyclic graphs, that allow you to explicitly and transparently show that causal structure using variables and arrows. So I'll give you a quick example of this. So this is an example of a directed acyclic graph where you have the diabetes as the exposure and leading to ischemic heart disease. And really what I'm interested in is estimating the effect of diabetes on ischemic heart disease. What is the relationship between diabetes versus no diabetes on the outcome of ischemic heart disease? So a question of causal inference, right? But then I also appreciate that there's this thing, older age, which I know is causally related. So that's why the arrow sits there to ischemic heart disease, independent of diabetes. But also people who are older age tend to be more likely diabetic as well. So this is a classic sort of setup in a causal diagram for confounding, where you have a common cause, older age, of both the outcome and the exposure. And in this setting, you have to deal with the older age in some manner. And in an observational setting, you tend to deal with it by putting it into a regression model and adjusting for it. Or you match on it, or you stratify on it, whatever. You have to condition on it in some way to control it and keep it constant. Of course, the most effective way to do this in the context of an intervention, not like diabetes, but a pill, is to randomize. If you randomize, you effectively kill this arrow. And if you kill one of those two arrows, confounding, it disappears, okay? But in the observational setting, it's usually sort of adjusting for older age. Now, you can imagine, though, this can get very complicated, right? So, older age can lead to higher blood pressure. Diabetes can also affect higher blood pressure. There could be an ACE gene, and this is relatively simple compared to what can happen. So ultimately, you have to make some judgments on what you think are the main drivers of this causal network, of the relationship of the outcome. There are certain rules now that you can apply to this causal diagram that let you know which ones you should adjust for and which ones you can leave alone, okay? But someone might come along and say, well, that just doesn't look right. You've got this variable. That's fine. But at least now we can have an explicit and transparent discussion about what we think is the right causal structure. Previously, you just kind of made it up and you sort of decided to enter the model because that's how you felt like. But that's not the way you should be doing it. There needs to be transparency and not necessarily objectivity. There's a lot of subjectivity in science, right? We make decisions about what variables we enter and so forth, but at least transparency and a systematic approach is very important. The other piece around variable selection that I wanted to highlight, apart from type, is number, the number of variables you enter. And so it's a regression modeling. One of the most important strategies is not to overfit the model, meaning entering too many variables, because you'll then start to fit noise as opposed to the actual relationship of interest. And so the model becomes unstable. Instead of saying variable, however, when you talk about sort of the number of covariates or variables you enter into a model, you should really be talking about variable levels, not the actual variables themselves, because that's what uses up what's called the degrees of freedom of the model. Think of it as how predictive or what the model can do. The more variables put in, the more constrained it is a little bit, and the more unstable it gets. So, for example, if you have a race variable that has 3 levels, right? So white, black, or other, for example, one of those levels will be the referent, and you'll then have 2 levels go into the model, right? So those are going to use up 2 levels. So even though race is a variable, one variable, it's going to have 2 levels used up in the model. And that's how you should think about it in the context of deciding how many variable levels you want to use up in a model. And so some of you may have heard the 10-to-1 rule, where you want to sort of at least have 10 patients or 20 patients in a sample for every variable level you enter into the model, okay? And that's generally not a bad rule of thumb, although the larger the better, 20 or more is preferable. However, how you apply this depends on the actual outcome and the way that outcome is defined. And this table helps you to understand that. So if the outcome is a continuous measure like systolic blood pressure, that's the outcome of your model. It's typically modeled in a linear regression model. Then the limiting sample size or the number of patients that you would sort of look at relative to the number of variable levels you incorporate is the total sample size. Why? Because every single patient contributes a systolic blood pressure, okay? And so therefore, if the sample size is 100, then theoretically you could have 10 covariate levels or variable levels in your regression model, okay? The more the more that ratio is bigger, the better. So less than 10 is even better, if at all possible. So the larger the sample size, the more flexibility or degrees of freedom you have in terms of incorporating those variables. If you have a binary yes/no outcome, which is typically modeled using logistic regression, then the power or the statistical power of the model is not driven by just the outcome itself, but it's the less common of the two. Of the yes/no outcome, okay, or the variable of interest, okay? So it's the less common of the two. So if you have 100 patients and 70 have the outcome of interest and 30 do not, then the number of covariate levels you can enter if you use that 10-to-1 rule is not 7, it's going to be 3. So even though you had 70 outcomes, divided by 10 is 7, the less common of the two is what drives the statistical power of that analysis and how many covariate variable levels you can enter. So that's the 3 of it, the 30 divided by 10 or 3. And finally, the other group of sort of outcomes is the failure time outcome, the survival outcome. And therefore, in that context, it's the number of patients who have the event of interest. So therefore, in a failure time data set, it turns out the most statistically powerful failure time data set is when everyone has the outcome of interest over follow-up, right? Death, of course, is a classic one. Everyone dies. It's just a question of whether we can observe it at the end of follow-up. So typically, it's just the number of outcomes. So if you have a cohort of 100 people and 30 of them have the outcome of interest over the follow-up period, then the covariate levels that you'll be able to sort of work with, the degrees of freedom, is approximately 3. Okay, but again, the greater that ratio, the better. Okay, I think I see a question or chat here. Okay, survey. Thanks. Okay. All right, so we're starting to run out a little bit of time. I'm going to provide you a reference here. This is a paper that we published in Transplantation. Dr. Sunita Singh, who's been on staff now for a number of years at UHN, when she was a graduate student, we published this paper on multivariable regression models, principles and pitfalls in transplantation. So we hopefully find that useful, and it goes over a lot of the principles that I just mentioned. I'll just sort of highlight at a high level the points I want to raise about this particular issue, which is the follow-up data. Or typically a cohort study, and some of the issues that I find here. And the biggest issue I find with the analysis of cohort data is that a lot of times investigators love to use logistic regression on a mortality event where they think the mortality event can be coded as 1 or 0. And technically that is highly problematic because not everyone dies. of course, but also people have varying amounts of follow-up over which one can actually observe someone to die, right? And so in a failure time data set, some patients will not be observed for the entire period of time, and therefore their outcome will not be seen. Some of them will have the event at some point early on, but some of them may have had an event later on. So the point is the follow-up time is very, very important. But if you analyze the data like it was a binary outcome, yes, no, you're essentially assuming that you observed everyone to some fixed follow-up time, be it a year or 2 years. So everyone has that same amount of follow-up time, which is a very strong assumption if you don't, okay? And so that kind of cohort we talk about is called a closed cohort, where you've got a clear defined entry point and everyone has follow-up to some point or had the outcome of interest. Those are the only two options. Very unusual in that setting because most cohorts, so the closed cohort represented on the left side here, most cohorts are open cohorts where, yes, you can define some entry point like kidney transplant, but then over the follow-up period, depending on when the patients entered and so forth, they vary in terms of how long they can be followed up. So for example, if my cohort goes from 2010 to 2019 with follow-up to the end of 2020, then there's at least 1 year follow-up for everyone, but some patients could have had 10 years of follow-up who were transplanted back in 2010, right? So it varies depending on when the follow-up ends. And then some of them would have had the outcome of interest, which represents these dots. Some of them would not have had the outcome of interest up to the point of they were last followed up, which represents this arrow. You can also have what are called dynamic cohorts, where the entry is actually not seen until some later point. So I don't see a transplant patient today when they got transplanted, but they enter the cohort at some point a few months after their transplant, right? Maybe they got transplanted in some other country and they came in to my cohort, but at that point, they're already 3 months in. And the way you analyze those data are also a little bit different because this is what we call a left truncated analysis. And so it depends on what you're doing. But the bottom line here is, I'm going to skip this table, is that you'd never use logistic regression to analyze a cohort study where there's variable amounts of follow-up time in an open cohort setting. Otherwise, it'll induce selection bias. And so you should use appropriate time to event techniques, okay? Kaplan-Meier, Cox proportional hazards model, and so forth. The one time where you can use logistic regression is if you effectively have a closed cohort, and you can do so, for example, in a large study where you have 30-day follow-up, where you're looking at readmission, then you're effectively following everyone for that period of time and can enumerate all those who have readmission with a relatively low mortality rate. So therefore, in that setting, you can probably use logistic regression, but there still may be benefits to using a time to event analysis in that context. For example, with the logistic regression, you just assume yes, no, but maybe you want to also look at the kinetics of how quickly they're dying. And that can be done with the time to event analysis. I'm going to leave you with these three references. The middle one is the medical statistics reference from Kirkwood and Stern. It's an outstanding textbook. If you're going to buy one textbook, buy that one. It's an old one, 2003, and I understand a new edition is coming next year. So if you want to wait out, you can do so, but it's an excellent, it's geared towards medical students, but it covers the entire breadth of medical statistics in a beautiful fashion, provides data sets as well on their website, as well as code, SAS, R, Stata, so it's fantastic. The other two books that are flanking it are around epidemiologic study design and other statistical principles, causal inference. I find both of them excellent. If you're a clinical researcher who wants the nitty gritty and does a really good job, the left book by Hulley is really good. The one on the right, epidemiology by design, is a little more involved in terms of the causal inference piece. Okay, so this is a summary. Just the key points here is there's many misunderstandings and misuses of statistics. I'm hoping that sharing with you some of my insights will help you sort of lead you in the right direction in terms of using the approaches more effectively. I think it's really important for clinicians to have a knowledge of these things now, especially with the advent of big data and lots of data that's available to us. And sort of having venues like this, like Red Hot, is a wonderful way for us to disseminate that knowledge and continue to grow it in our sort of community. So thank you for joining me. Sorry for the going a bit over time, but happy to take any questions in the short time that we have available.
Thank you very much, Dr. Kim. That was incredible. Your passion for data is so infectious, and that presentation was so nice. It was really great that you put some of those really complicated statistical concepts into ways that we can understand, that I understood in my simplistic brain. Any questions? We've got just a few minutes left in the meeting today. I'm really grateful that you talked about the number of variables based on the population. I've seen that done a number of times where you have a sample size of 40 patients and you've got 40 variables, and you've got some biologically implausible thing that's all of a sudden statistically significant. So that was great that you went over that.
Yeah, and you know what? It's amazing how frequently you find that. It's because, people have the data set they have and they just want to sort of make the most of it. But unfortunately, it certainly leads to other problems. There are approaches to try to use the data sets more effectively, but that requires sort of prior distributions and other more sort of complex approaches. But anyways, I agree. I mean, these rules of thumb can keep you sort of on the right track, but nothing like having more data to help you make those inferences.
And Stephanie, did you have a question? You just took your camera off.
I did, but I don't want to.
No, go ahead. I was just going to fill time, so you go.
Hi, Dr. Kim. Thanks for your presentation. Hi. I just wanted to clarify. I've struggled with this before. You spoke about the difference between using like independent variables as predictors or confounders. And I kind of struggle with that whenever I'm writing like the statistics part of the paper, because they're kind of like, is that kind of semantics just based on the type of question you're asking? Sometimes I struggle with like how to describe what I'm saying. And sometimes you have maybe predictors and confounders in your same model. Do you mind just speaking to that a little bit?
Yeah, so it is a bit semantic, but it is important to clarify it. I agree with Stephanie. So I generally don't use the terms predictors because I find it not very helpful. It's not specific enough. All variables you enter in a model will have some prediction value, yes. But really, you have to be careful about what it is that you're using it for. And as I said, in the context, particularly in the modeling setting, it's either prediction as the goal or causal inference or inference, really. And so if prediction is the goal, these are typically, you can call them variables, covariates, features. Yeah, you can call them predictors as well, but ultimately the point is you want to try to get that outcome correct. In most of my studies where I'm actually interested in exposure outcome relationship, I talk about these additional variables as confounders, right? Because I've made a decision that entry of these variables in the model will help me come up with a more unbiased estimate of the exposure effect that I'm really interested in. So I'm very specific in that way, and that would be the general way that I would suggest. So if you're interested in causal inference about a given treatment effect or exposure, you call those other variables confounders. If you're doing a prediction model, then predictors, variables, covariates probably serve the purpose. But really, remember, their goal is really just to predict the why. And so you can sort of call it whatever you like. Confounder is probably not correct in that context because you're really interested in the prediction piece.
Right. So like to clarify, for example, a study that I'm interested in, like I do pediatric ID, as you know, so various infections and their kind of impact on ICU admission. So I have my key predictor, my key outcome, and then anything else. For example, concurrent bacteremia is not a predictor, it's actually a confounder.
It should, yeah, exactly. It is a confounder, but you have to determine that it actually likely is a confounder in advance before you enter the model. And the directed acyclic graphs can be helpful in that regard. But yes, you're absolutely right. And just before we close, because it's 5 o'clock, just related to this, a lot of times we love to do studies where we just show a group, and I've done this too, a table of predictors or variables with their hazard ratios, right? That's not very helpful. And so if you want to predict something, do the prediction. I don't care about the individual coefficient values. I want to know what the actual prediction is. If you're trying to make a causal inference, I want to know the beta of the exposure or treatment variable of interest. All the other stuff is there for adjustment. And so really the values of the covariates or the coefficients of those other variables really are not very helpful. And I'll leave you with a paper that you can look up in Google called the Table 2 fallacy, which articulates this very, very well. Okay, the Table 2 fallacy.
Thank you.
Excellent. Thank you so much. Thanks, Dr. Kim. That was great. Thanks for everybody for joining today. Look forward to another couple of red hot webinar sessions at the CST annual meeting and the Fellows Symposium in Montreal this year in October 14th to the 18th. Those will be the next 2 sessions for our red hot webinar series for this year. Thank you again, everybody, and have a great rest of your day.
Thanks, everyone. Cheers. Bye-bye.
Thank you.